Uh, I'm not sure if you can hear me or not.
Yes.
Okay, let's start then. First of all, I would like to tell you something about the most common pathological changes connected with secondary glomerulopathies, and this is diabetic nephropathy. I would also like to tell something about another secondary glomerulopathies, like, for example, hypertension nephropathy, systemic lupus erythematosus, and the light chain deposit disease. Um, if we will have quite enough time, I will tell you about myeloma-related kidney diseases and also about solid tumor associated with glomerular diseases. The first is diabetic glomerulonephritis because it is the most common secondary glomerulopathy all around the world. In the past, it was known as diabetic glomerulopathy or diabetic nephropathy, but nowadays would like rather to use the name diabetic kidney disease because, as we found, diabetes mellitus can injury not only the glomeruli, but also it can injury the tubules of the kidneys, as well as the blood vessels, and also some urinary tract, meaning the bladder, which is in diabetes mellitus, which is coming to be a neurogenic bladder. So this is why nowadays we'd rather try to use the name diabetic kidney disease. It is, of course, the new name, but you can use the old names like diabetic glomerulonephritis or diabetic glomerulopathy. What does it mean, in fact, diabetic nephropathy? Well, we can recognize diabetic nephropathy when we observed a persistent albuminuria over 300 milligrams per day. This is over 200 micrograms per minute. It must be confirmed on at least two occasions, 3 up to 6 months apart. Diabetic nephropathy, another point is the decrease in GFR level and high blood pressure, meaning systemic hypertension. If you will find all these three elements together, you can recognize diabetic nephropathy. The diabetic nephropathy is very common all around the world nowadays, as I've told you, but how many people are suffering from diabetic nephropathy? It is claimed that nowadays it is over 500,000 people, 500 million people, sorry, and it is projected then in 2045 it would be over 700 million people all around the world. This is about 8 up to 10% of the global population. As you all know, there are two main forms of diabetes mellitus, the type 1 and type 2. Type 1 is also called insulin-dependent diabetes mellitus, whilst type 2 is called non-insulin dependent diabetes mellitus. The first one constitutes 5 up to 15% of diabetic nephropathy. The second one constitutes over 80 up to 95% of all people suffering from diabetic nephropathy. Diabetic nephropathy is nowadays the leading cause of end-stage renal disease. Both types of diabetes mellitus can lead to end-stage renal disease. In some countries, like United States, there are almost 40% people with end-stage renal disease suffering from diabetic nephropathy. But in the other countries, the percentage is even higher. For example, in Israel, Korea, Hong Kong, Taiwan, Japan, New Zealand, and Philippines, there are almost 40 up to 50% patients with end-stage renal disease because of diabetic nephropathy. And finally, in the years 2009 and 2000 up to 2011, Malaysia, Mexico, and Singapore claimed that in these countries, the percentage of people with end-stage renal disease and diabetic nephropathies reached almost 60% of patients. Of course, the incidence of end-stage renal disease due to diabetes rises in the older age groups. Diabetic nephropathy has specific histological changes, and these changes are connected with, first, mesangial expansion, which is, as it is claimed, directly induced by hyperglycemia, thickening of the glomerular basement membrane, and finally, a glomerular sclerosis leading to general hypertension. And glomerular sclerosis is because of intraglomerular hypertension. On this slide, you can see a typical syndrome, which is called Kimmel-Still-Wilson, and is seen in the kidneys of people suffering from diabetic nephropathy. On the left-hand side, you can see a normal glomerulus, whilst on the right-hand side, you can see a changed glomerulus with the sclerosis. The Kimmel-Still-Wilson was firstly described, sorry, I don't know if I have the slides, but I would like to tell you something about two guys, because it is in the one name. I would like to tell you something about these two guys who detected and firstly described the Kimmel-Still-Wilson. So let me show you once again this slide. Kimmel-Still was in fact a German Jew born in 1900, and he was a pathologist. In 1930, he decided to run away from Germany because of Nazi, and he decided to visit United States. He got a scholarship in Harvard University. Almost in the same time, a special scholarship was given to Wilson. He was, on the other hand, he was an Englishman born in London in a Baptist family, and he was a doctor. His specialization was internal diseases, and in the further future, he also was very interested in hypertension. So he was one of the most well-known all around the world doctors who was taking care about the blood pressure of his patients. So these two guys met in Harvard University in early 30s. It was maybe in 1932, because in 1934 they described the syndrome, which consists of sclerosis of the glomeruli, and of course thickening of the glomerular basement membrane and hyperfiltration in the glomeruli. So it is nice to know who was who, I would say. As regards the risk factors of diabetic nephropathy, there are some modifiable and some unmodifiable risk factor. To the main modifiable risk factor, you can put hypertension, glycemic control, dyslipidemia, and also active smoking. Of course, the last risk factor is maybe not very strong, because only some studies are showing that smoking cigarettes can be a modifiable risk factors, whilst the other studies don't claim so. As regards unmodifiable risk factors, these are age, the elderly age, race. The Black people are much more frequent on risk factors of diabetic nephropathy, and finally the genetic profile. As regards the cause of diabetic nephropathy, up to now, we don't know the exact cause, but it is claimed, it is postulated that the mechanisms of diabetes injury of the kidneys can be as follows. First of all, hyperglycemia. It is claimed that it is causing, first of all, hyperfiltration in the glomeruli, and on this way can lead to the renal injury. Second, hyperglycemia is responsible for advanced glycosylation and products forming in the kidneys. As you know, advanced glycosylation and products, these are long-lasting proteins like collagen, for example. As you remember, collagen is forming the basement membrane of the glomerulus. So these are so-called long-lasting proteins, which are glycated on an enzymatic way. Another point taking maybe an important part in the injury of the kidneys is activation of cytokines and, of course, some hemodynamic alteration. This alteration are connected with microalbuminemia and then overt proteinuria, and can lead to the decrease in GFR level. This is one point, and the second is general developing of general hypertension, means systemic hypertension. Hypertension is an adverse factor which can make a progress of injury of the kidneys faster. Another causes which are claimed to be, which are postulated to be causes of diabetic nephropathy are connected with our genetic genetic factors. There are some ethnic groups in which we can observe much more higher percentage of diabetic nephropathy than in the others. For example, these are Afro-Americans, but also Indians, Pima, living in United States. There is also found that over 16 genes can have a polymorphism leading to diabetic nephropathy. The one of the best known gene which has a great influence on forming diabetic nephropathy is the polymorphism of the gene for angiotensin converting enzyme. The frequency, as regards the frequency of diabetic nephropathy, the peak of the onset of nephropathy in patients with type 1 of diabetes mellitus is between 10 up to 20 years of duration of diabetes mellitus. But in patients with type 2 diabetes mellitus, the diabetic nephropathy can be found much earlier. It is found even after 2 up to 10 years of duration of diabetes mellitus. Why? Because, as you know, in patients suffering from diabetes mellitus type 2, diabetes mellitus type 2 is living even 5-6 years earlier than we can detect it. We can detect it occasionally, something like, by the way, for example, the patient is sent into the hospital because of a stroke or heart attack. And by the way, we can find that the patient is in fact suffering from diabetes mellitus from some years. This is why it is quite enough to live even some years, for example, 5 years, no longer, to detect diabetic nephropathy in such patients. The first sign of diabetic nephropathy must be albuminuria. In patients with much more advanced diabetic nephropathy, we even can find overt proteinuria. As regards the frequency of end-stage renal disease because of diabetic nephropathy, we can found that 20 up to 40 patients with type 1 diabetes mellitus can achieve end-stage renal disease, but only 10 up to 20% of patients suffering from diabetes mellitus type 2 can develop end-stage renal disease. Why? Because they are elderly people and they can die because of quite different complications, like, for example, complications connected with some abnormalities of circulatory system, from strokes or for example, some neoplasmatic diseases. And this is why end-stage renal disease because of diabetic nephropathy is nowadays observed much frequent in type 1 diabetic patients. But of course, you must remember that chronic kidney disease and diabetic nephropathy is much more frequent observed in patients with type 2 of diabetes mellitus. It is claimed that the frequency is even 5 up to 10-fold higher than in insulin-dependent diabetes mellitus disease. As regards race, it is found that the severity and the incidence of diabetic nephropathy is much greater in Black individuals than in white individuals. And the frequency in Black individuals is even 3 up to 6-fold higher than in white individuals. Patients patients suffering from type 2 diabetes mellitus and having overt proteinuria, if they have also changes in the fundus of the eye, meaning they have retinopathy, these are patients who must have diabetic nephropathy, because on the fundus of the eye, we can find the same caliber of blood vessels then we can find also in the kidneys. So this is why in the past we claimed that there is no diabetic nephropathy without diabetic retinopathy. So we can say that it is very useful to examine the eyes fundus every year at least in order to find if there are some changes typical for diabetic retinopathy. And if we will find such changes, we can suspect that the patient is also suffering from diabetic nephropathy. How can we recognize the diabetic nephropathy? First of all, it is very useful, the history of diabetes. It must be last at least 5 years or even longer, especially in diabetes mellitus type 1. It must be at least 10, 15 years of duration. Second, is very important to ask the patient if he or she is passing of foamy urine, because passing foamy urine, this is a sign. This is a sign that the patient has an overt proteinuria. And finally, if we will find diabetic retinopathy, we can suspect without the renal biopsy that the patient has diabetic nephropathy. Because of huge hypoalbuminemia, you can find in patients with diabetic nephropathy edema, which are secondary to hypoalbuminemia. These are peripheral edema, but we can also find some pleural exudate. And finally, we can find some another disorders associated with diabetic nephropathy, like peripheral vascular occlusive disease, hypertension, or coronary artery disease. On this slide, you can see changes typical for diabetic glomerulosclerosis. You can see the scleralization inside the glomerulus. These are some spheric structure without the cells. On the upper picture, you can see it on the left-hand side, and also on the left-hand side, you can see on the lower picture, just here. I really don't know if you see my pointer or not. Okay. Of course, physical examination is also important to sustain the hypothesis that the patient is suffering from diabetic nephropathy. First of all, we can find in some individuals, or I should say in the majority of individuals with diabetes mellitus, hypertension, because hypertension is present in more than 60% of patients with advanced stages of diabetic nephropathy. Another you can find in such patients, these are signs of peripheral vascular occlusive disease, some neuropathy connected with diabetes, and finally edemas, as well as non-healing skin ulcers, leading also to osteomyelitis. These are the most common signs of advanced complications of diabetes mellitus. How can we confirm the diabetic nephropathy? First of all, it is good to perform an urine analysis. Nowadays, it is recommended to perform urine analysis in every patient suffering from diabetes mellitus at least once with 1 year. Second, it is looking for proteinuria and glucosuria. Glucosuria can inform us about not good control, metabolic control of diabetes mellitus, whilst proteinuria lower than 300 milligrams per day can inform us that it is only that these are reversible changes, but if the daily proteinuria is over 300 milligrams, we can say about overt proteinuria, and unfortunately, these changes aren't reversible. Okay. I can. In the blood analysis in diabetic patients, first of all, you have to look for the creatinine and urea and also uric acid levels because they are elevated in the kidneys injury. They are elevated, but the GFR level, described according to the MDRD formula, is coming down. So all these signs can confirm the injury of the kidneys. You will also find in such patients an elevated level of glucose as well as an elevated level of glycated hemoglobin. As regards morphology, you can find a kind of anemia, which is especially good seen in advanced stages of diabetic nephropathy connected with huge injury of the kidneys. Sometimes you can also find hypoalbuminemia and hypoproteinemia together with hypercholesterolemia. These findings are especially well seen in patients with nephrotic syndrome, of course, because of diabetic nephropathy. Of course, you will also find some dyselectrolytemia parallel to the stages of diabetic nephropathy. And these are elevated, decrease or elevation of sodium level, usually elevated level of potassium and phosphorium, and decrease in calcium level. These findings are typical also for the stage 4 and 5 of the chronic kidney disease because of diabetic nephropathy. So these are advanced stage 4 and 5 of chronic kidney disease. These are so-called advanced stages of chronic kidney disease. If you performed the renal ultrasound examination, you will find that at the beginning of diabetic changes in patients, you can see the normal or even elevated size of the kidneys. Elevated size is because of the hyperfiltration and expansion of the mesangium in the kidneys. If you will perform the renal but in the advanced stages, especially in the 5th stage of chronic kidney disease because of diabetes mellitus, you will find kidneys shrunken. I would say they are rather small. renal biopsy, in fact, isn't need to confirm the diabetic nephropathy unless you have a young patient and you are not sure if it is quite enough time to develop diabetic nephropathy, because sometimes in young people we will find another diseases like for example primary glomerulonephritis with proteinuria, overt proteinuria, even with nephrotic syndrome, and together with diabetes mellitus. And in such case, if the patient is suffering from diabetes mellitus a short time, short that means let's say 5 up to 10 years, and the metabolic control of glycemia is good, it is worth to perform renal biopsy, because maybe this young man or woman is suffering not from diabetic nephropathy, but she is suffering from another kind of glomerulopathy, like another type of primary glomerulopathy. Sometimes it occurs. So in such case, it is recommended to perform renal biopsy in order to be sure which one disease caused proteinuria. As regards natural history of diabetic nephropathy, the natural history was described many years ago by Mr. Mogenson, as I suppose he was a man who was born in Norway, or I suppose it was Norway, and he described as the first 5 stages of development of diabetic nephropathy. The stage 1 is connected with hyperfiltration, hyperfunction, and secondary to that, hypertrophy of the glomeruli. We can observe increased GFR level in both types of diabetes mellitus because of hyperfiltration. The GFR level can be as high as 120 milliliters per minute, or even 140 milliliters per minute. Albumin excretion is not observed, or if it is, it must be very, very small. In both types of diabetes mellitus, we observed no hypertension, and at the time of diagnosis, we can see these changes. As I would say, I would like to highlight that histological changes in the kidneys in people suffering from diabetes mellitus are starting to be seen at the beginning, at the first moment when diabetes mellitus is forming. So it is very important to remember that these are very small changes, like hyperfiltration. It is only a functional change, but the thickening of the basement membrane can be seen under electron microscopy investigation. The second stage of diabetic nephropathy is usually called silent stage because we can see thickening of the basement membrane and the expansion of mesangium under kidneys biopsy, but there is a normal level of GFR. Of course, the GFR level is coming down, but it is near the normal. It is still over 90 milliliters per minute. sometimes we can observe albuminuria, but it is microalbuminuria, and this albuminuria is reversible. It is very important then that if you will give the patient ACEs or sartans, you can reverse almost completely or even completely the microalbuminuria, whilst overt proteinuria can't be reversed. In type 1, the blood pressure is usually normal, but in type 2, we can observe mild up to moderate hypertension. And this time is taking 5 first years of diabetic nephropathy disease. The third stage is called incipient stage, because in this stage we can find microalbuminuria and the beginning of falling down of GFR level. So it is starting to be less than 90 milliliters per minute. We can also observe the daily excretion of albumins over between 30 up to 300 of milligrams per day. In type 1 of diabetes, we usually observed not hypertension yet, but a little bit elevated values of blood pressure, whilst in the type 2 we can see overt hypertension. This period is claimed takes about 10 years of duration, and it is between 6 years up to 15 years after the beginning of diabetes mellitus. Stage 4, this is a stage which is connected with overt proteinuria. So we observed a huge proteinuria, usually over 1 gram per day. Sometimes it can be nephrotic range proteinuria. GFR is below the normal level, and in both types of diabetic patients we can observe hypertension. It is observed usually 15 up to 25 years after the beginning of diabetes mellitus. And finally, Mogensen described the last stage, the 5th stage, which in fact is the same or parallel with the 5th stage of chronic kidney disease. This is in fact end-stage renal disease. Patients are uremic. We observed the GFR level less than 10 milliliters per minute. And what is important, we can sometimes observe the decrease in daily proteinuria because there are not enough living glomeruli to excreting proteins. In all patients, there is a hypertension, and this stage is observed usually between 25 up to 30 years after the start of the beginning of diabetes mellitus. Wow. I suppose that it was a little bit difficult, but it is in fact very important to remember these stages, and it is very useful to describe the patients. Another point very important for us, for clinical doctors, is if we are able to prevent diabetic nephropathy. And the answer is yes. The crucial thing is a good glycemic and metabolic control. We have to do everything to optimize glucose level in the blood, as well as the level of glycated hemoglobin, it should be less than 7% in type 2. In type 1, even it should be circa 6%. So in order to get a good glycemic and metabolic control, the point is intensive therapy to achieve a good values of glycemia. They can, the good glycemic control can lead to reverse glomerular hypertrophy, hyperfiltration, and in fact to delay the development of microalbuminemia. Another point as regards sorry. Another point is connected with the diet. It is very important to achieve euglycemia. So you have to reduce carbohydrates intake as well as protein intake. Reduction in carbohydrates intake can improve the body mass index and also can achieve a proper values of glucose level, also glycated hemoglobin level. As regards protein intake, it is very important to sustain the rules given us by MDRD group, because as you know, this formula MDRD get a name from the group MDRD, and that means modification of diet in renal diseases group. In 2004 in United States, the group of nephrologists and the dietitians describe some rules as regards reducing protein intake in patients suffering from chronic kidney disease. And they say, for example, then in the stage 3 of chronic kidney disease, you have to reduce protein intake to 0.8 gram per kilogram of the body weight per day. And in the stage 4, you can you have to reduce the protein intake up to 0.6 gram per kilogram per day. This reduction can lead to avoiding forming too much proteins and products like creatinine, urea, and uric acid. As you know, all these products are eliminated from our body by the kidneys. So if you reduce the intake of the proteins, the formation of protein and products would be lower, and it can give the kidneys a chance to output all these products away from our body. It is also important and worth to highlight it that in all patients suffering from every kind of nephropathy, especially in hypertensive or diabetic nephropathy, it is very important to reduce the salt intake, because salt intake is leading to hypertension. In patients in whom we observed hypertension, it is very important to achieve a good control of blood pressure, to do everything in order to achieve the value at least lower than 140/90, and even lower than 120/70. Why? Because it is very important to reduce hyperfiltration inside the glomeruli. It can prevent the injury of the glomeruli, and in general, it can prevent the patient from some cardiovascular complications. As regards the antihypertensive treatment in patients with diabetic nephropathy, we try to achieve the lowest good tolerable blood pressure in the patient. In order to do it, we start with giving the patients ACEs, or if they aren't good tolerable, we give sartans instead ACEs. But please remember that ACEs delay the development of diabetic nephropathy because they can reduce the albuminuria as well as overt proteinuria. They preserve on this way GFR level, and on this way ACEs as well as sartans have nephroprotective activity. Another also stabilization disease connected with the injury of the kidneys is, of course, hypertension. Hypertension is especially dangerous because it can lead to coronary heart disease, to strokes, congestive heart failure, as well as peripheral vascular diseases, and finally to the chronic kidney disease. So it is very important to avoid hypertension complications. And because of it, we have first tried to identify all patients with hypertension and treat these patients as good as it is possible. Of course, it is very important to change the lifestyle of the patient suffering from hypertension into a healthy type of lifestyle. It is also very important to reduce the prevalence of hypertension in general population. There are some recommendations which can prevent forming hypertension. First of all, low salt diet. That means that the intake should be lower than 6 grams of sodium per day. Second, it is important to highlight the reduction of the body weight in order to achieve so-called the ideal body weight. Third, it is very important to get a proper lipids profile, because in some patients we can also observe hyperlipidemia, and hyperlipidemia, as you know, can lead to atherosclerosis. Atherosclerosis is connected with the constriction of the constriction and the stiffness of the blood pressure, and on this way we can observe hypertension. Adequate water intake is also very important, because if the patient is overhydrated, we can observe hypertension. It is also important to improve the diet of patients suffering from hypertension, or not suffering yet, but in order to reduce the possibility of hypertension. So it is a diet low in proteins, means vegetarian diet, which is rich in potassium, which consists of fruits and vegetables in the majority. So it is very important to eat no more proteins than 1 gram per kilogram of the ideal body weight per day. And finally, it is important to reduce the alcohol intake. I don't say to eliminate alcohol. Nevertheless, nowadays it is claimed that even the smallest amount of alcohol can be dangerous for our body, for our health. I would say reduction of alcohol intake is important. Also, it is important to recommend the patients some sports, some gymnastic, and checking the blood pressure every month, for example, in order to find as well as quick as it is possible changes in our blood pressure. Well, here are the normal values of the blood pressure and pre-hypertensive values, stage 1 and stage 2 of hypertension. So this is the definition of hypertension in order to remember you the hypertension definition. I suppose that you know that the regulation of blood pressure is dependent, first of all, of cardiac output, and second, because of peripheral vascular resistance. As regards cardiac output, it is connected with sodium intake, renal function, and the action of mineralocorticosteroids. And as regards the peripheral vascular resistance, it depends on the systemic nervous system and some humoral factors, for example, producing by the kidneys. Maybe you know the group of substances which are called prostaglandins. All prostaglandins are leading to constriction of the blood vessels, but the only one means PGE2 is responsible for the lowering the blood pressure because it doesn't constrict the blood vessels, but is leading to the opponent phenomenon. As you know, the hypertension can injure the kidney. This is possible on the way as follow. The systemic high blood pressure can lead to the reduction in the blood flow in the kidneys. Because of it, we can also observe the increase of the resistance of efferent glomerular arteriole, and because of it, we can observe the hypertension inside the glomerulus, which is secondary to efferent glomerular arteriole constriction. Because of hyperfiltration, we can observe albuminuria, and in the future also overproteinuria. Albuminuria is leading to developing glomerulosclerosis and impairing renal function, and in fact the last stage is end-stage renal disease. So on this way, hypertension can injure the kidneys. The very well-known fact is that in the patients with injured renal function, we observed an elevated blood pressure level. For example, it is claimed, it is found, I would say even, that in patients with stage 3 of chronic kidney disease, more than 60% patients reveal high blood pressure. The percentage is even 90 and more, in patients with stage 5, means with end-stage renal disease. The injury, the hypertensive nephropathy, you can see on this slide. You can find on the slide that hypertension, general hypertension, can lead to constriction of arterioles and can lead to the thickening of the walls of capillaries, and on this way, sclerotization of the glomeruli. And it can lead further to inadequate perfusion of the blood through the glomeruli, and we can observe not only the injury of the glomeruli, but also the decrease in GFR level. And finally, because primary, we can observe the injury of the glomeruli, but finally, we can also observe the injury of the interstitial tissue. And the injury of the interstitial tissue is leading to the interstitial fibrosis. On the next slide, you can see changes observed in the glomeruli. You can here see the sclerotization of the glomeruli. Here is, let's say, one good glomerulus. And unfortunately, this is a type of malignant sclerosis, which can lead to a hypertension, which is very, very high in fact. Okay. I have more than 150 slides, so trying to look for the most important slides to discuss them with you. Hypertension can lead in the kidneys also to volume expansion and to injury of the glomeruli, because we can observe hypertension inside the glomeruli. It can lead to activation of the renin-angiotensin-aldosterone system, because renin is locally produced in the glomeruli. It is, of course, produced in general and is getting the general circulatory system. So we can observe the elevation activity of the system of renin-angiotensin-aldosterone. And this is why the first step in the treatment of hypertension nephropathy is giving the patients ACEs. It is also very important because, for example, on this slide, you can see the fibrosis, not only sclerosis, but also fibrosis of the glomeruli. And as you maybe remember, the ACEs are responsible for reducing the fibration process in the glomeruli. On the next slide, you can see the malignant hypertensive nephropathy. The arrow is showing you the thickening of the wall of a capillary, of a blood vessel inside the interstitium. As I've told you, the first step nowadays in patients with hypertension, as well as in patients suffering from diabetic nephropathy, is using ACEs, because ACEs can reduce intraglomerular pressure. On this way, can reduce also the albuminuria as well as overt proteinuria. And on this way, they have a nephroprotective as well as a cardioprotective action. Cardioprotective action is primarily described as stopping fibrosis, or not maybe stopping, but at least reducing fibrosis and remodeling of the left ventricular region. The action of ACEs as well as AT1 blockers, this is the another name of sartans, is that ACEs can lead to a decrease in efferent glomerular arteriolar constriction, leading to intraglomerular pressure decrease, and finally on this way leading to lowering daily albuminuria. And because of lowering albuminuria, we can suspect less injury of the kidneys. Okay, now I suppose I have some time to show you some information about systemic lupus erythematosus. As you maybe know, systemic lupus erythematosus is a systemic disease, much more frequent observed in women, usually adult women, than in men. Lupus nephritis is the most serious manifestation of systemic lupus erythematosus and is observed in at least 60 up to 90% of patients suffering from SLE. The symptoms of lupus nephritis are hypertension, proteinuria, and renal failure. Of course, this renal failure is all over in progress. Lupus nephritis, is usually found in young adult women, and it is 9, even 10 fold much more frequent in women than in men. As regard the prognosis, it is better for patients who don't have lupus nephritis, but if it occurs, it is very important to recognize the type of the kidneys injury and trying to improve the course of systemic lupus erythematosus. Here are the causes. Up to now, we really don't know the proper causes of SLE, but as you know, as you see, first of all, it must be gender, also some genetic factors. It is postulated and it is found that HLA class 2 genes are taking part in forming SLE, also some complement genes, as well as environmental factors which can be trigger mechanisms take part in forming SLE in patients. Mechanism of immunological response, these are immune complexes, and immune complexes can promote an inflammation response by activating components of complement. And on this way, we can observe the injury of many organs, and between them, there are kidneys. We can confirm the diagnosis of SLE by detecting some autoantibodies, which are anti-DSA, dsDNA antibodies, very typical for systemic lupus erythematosus, Also, the decrease in level of C3 or C4 components of complement, the presence of antinucleosome antibodies, as well as some changes in urine analysis, which are proteinuria. The level of daily proteinuria can be different. Sometimes it is less than 1 gram, but sometimes it is a huge proteinuria, higher than the nephrotic range, higher than nephrotic range. We can also find some red cells casts in urine analysis, together with red cell casts erythrocytes, and we can also find sometimes some leukocytes. And because the culture of urine is, in the case of SLE, negative, this is why we say that it is a negative puria. In some individuals, we also observed parallelly to the changes in urine analysis, the injury in renal function as regards the level of creatinine and urea, as well as the level of GFR. Of course, urea and creatinine are elevated, whilst GFR level is decreasing. Another test which can confirm the diagnosis of SLE, these are CRP level, which is generally not elevated in SLE, but in SLE is elevated sedimentation rate, and it is typical. Also, C3 and C4 components of complement can be decreasing, and it is very important because the decrease in C3 or C4 component of complement is very typical for another relapse of SLE. And it is a prognostic factor. So first of all, we can observe the decrease in C3 level, and then we can observe some clinical changes typical for the relapse of SLE. Okay, so it is very important to perform renal biopsy in all individuals in whom we suspect that there is an involvement of the kidneys within the process of SLE. On this slide, I took this slide from internet, so it isn't my work. And I would like to highlight that it isn't my work, but it was available in internet. So you can see the World Health Organization classification of lupus nephritis. The class 1, this is normal glomerulus. Class 2, this is mesangial proliferative glomerulonephritis. The class 3, this is focal and segmental proliferative glomerulonephritis. And type 4 is diffuse proliferative glomerulonephritis. The class 5 is so-called membranous glomerulonephritis. And finally, class 6, this is glomerular sclerosis. That means that it is the end of life of the glomeruli. On the next slide, I think it is a quite nice slide, because on this slide you can see in the upper part, you can see the pictures from from light microscopy, and this is hematoxylin and eosin staining. The second part, this is the picture from immunofluorescent microscopy. The third one, this is the picture from electron microscopy, and just below you can see the schema. So this is a single capillary, and you can see the mesangium region, red and gray, podocytes, which are green, and you can see if something is going on inside the capillary, like in class 4. On the next slides, I put, and this is my work, my own work, I put some information, what we can see in the different classes of systemic lupus erythematosus in the glomeruli. The class 1, you can see minimal mesangial lupus nephritis. That means that it is only a minimal increase of mesangium region and mesangial proliferation. In immunofluorescent microscopy, you can see some mesangial immune deposits, and clinical manifestation is usually mild proteinuria, nothing more. Of course, you can see some erythrocytes, some red cells cast, but nothing more. Class 2, this is a mesangial proliferative glomerulonephritis. You can see on a light microscopy investigation the proliferation of the mesangial cells and the increase of mesangial matrix. And you can see also under immunofluorescent microscopy some immune deposits located subepithelial and subendothelial. The clinical manifestation is asymptomatic hematuria and or proteinuria, and this type doesn't in fact need a specific therapy. Of course, it is worth to highlight it that we give the patients ACEs in order to reduce proteinuria, daily proteinuria. On the next slide, you can see a class 2 of systemic lupus erythematosus. On the next slide, on the other hand, you can see class 3. This is focal lupus nephritis. That means that we observed active or inactive focal segmentation of the glomeruli. Less than 50% of glomeruli are involved in the pathological changes. And in these patients, we usually observed hematuria with moderate proteinuria. In some patients, we can also observe the worsening of the renal function. Here is the typical for the typical focal lupus nephritis with some segmental changes, like for example here. And here you can see that the regions must be almost quite good. The class 4 of diffuse lupus nephritis, this is diffuse lupus nephritis. You will observe usually active, diffuse, segmental, or global glomerulonephritis. Global, that means that more than 50% of patients are involved. And clinical manifestation of this class is usually hypertension, edema, because of nephrotic range proteinuria, and also we observed
extrarenal involvement in many patients suffering from this type of kidney involvement. On this slide, you can see diffuse lupus nephritis with changes inside the blood vessels. Here you can see the increased number of the mesangial cells, as well as the increase of mesangial matrix. The fact is that you can see the shape of the glomerulus. Here you can see, because you can see the shape of the Bowman's capsule, but inside you can't see, almost you can't see the lumen of the capillaries. The class 5th of systemic lupus erythematosus is connected with the diffuse thickening of glomerular basement membrane, which is in fact membranous nephropathy, leading to huge proteinuria, nephrotic range proteinuria. And in these patients, we observed also in clinic, we can observe edemas, hypoalbuminemia, hyperlipidemia. On this slide, you can see in staining with argentum, the thickening of the basement membrane of the capillaries. And the 6th stage, this is advanced sclerosis in lupus nephritis. Clinically, we can observe people with very advanced chronic kidney disease with GFR level usually less than 15 milliliters, or even end-stage renal disease. And on this slide, you can see that there are no glomeruli because all of them are sclerosed, completely sclerosed. There are no proper glomeruli. Okay. What is the treatment? The treatment of lupus nephritis, of course, depends on the class of the systemic lupus erythematosus. In the class 1, there is no specific therapy. In class 2, the patients are given prednisone in low doses. It is usually the dose of 0.5 gram per kilogram. Sorry, I'm looking. I have another one lecture for the Polish students, so I'm trying to end my presentation. I would like to say that in the advanced stages, particularly in active, okay. In active lupus nephritis, like class 3 and 4, pulses of methylprednisolone are given, followed by orally giving of prednisone in a dose of 1 milligram per kilogram of the body weight per day. After 4 weeks, the dosage of prednisone is reducing every week of 5 milligrams lower. If prednisone and methylprednisolone alone aren't quite enough, in class 4 and 3, methotrexate can be given, whilst in the 5th stage, we'd rather try to give the patients mycophenolate mofetil nowadays. And finally, in class 6, unfortunately, there is no way to treat SLE, but there is a possibility to treat end-stage renal disease. And this is our aim, to treat end-stage renal disease. And if it is possible, to try to do everything to transplant the patient. Unfortunately, my time is over, so I have stopped on this my presentation. It was very nice that you decided to join to me, and thank you all of you for your attention. And I would like to wish you a good, nice afternoon. So thank you once again, and goodbye.
Thank you.
Thank you.